it is about partial breast radiation. So partial breast radiation, I'm not sure if it's a subject for the Middle East because, but we still need to know. To be honest, I'm working at Sultan Qaboos since last August, so it's already like 8-9 months. And I do primarily breast, so participate to the breast MDT, and we discuss 20 patients every week. And after 8 months, I've seen 0 patients eligible for partial breast radiation because the patients that we have in the Middle East are younger, because they tend to be very aggressive. They are node positive, they are large, they are Ki-67 elevated, low lymphovascular infiltration. So, but I think we need to know because not every patient is like an Omani or Saudi or an Emirati patient. We also have population which are aging and are diagnosed with mammogram. So mammogram is definitively a key for breast cancer mortality. And what I'm showing you on the left is a very old graph where you see in the UK, breast cancer mortality was increasing. And then around the 1990, they implemented mammography screening systematic for all the population, same in the US. And what you see that we have halved the mortality of breast cancer. And this slide is from Sir Pito, so the guy who set up the Oxford group, meta-analysis, the EBCCTG. And if you look well, in the Western world, and I'm taking here the data from the US, the SEER in 2022, you see that 2/3 of the patients are diagnosed at a localized stage, meaning they are not spread to the lymph node. And the 5 years relative survival compared to the population is 99.1%. So we are doing very well for breast cancer in the Western world. But again, this may not be the population that we have in the Middle East. So those patients that we diagnose at early stage, and this is a nomogram from the IBTR, so taking patient from Canada, from British Columbia, validated in Boston. Let's take a typical patient. She's more than 60 years old. She has a small lesion diagnosed by mammogram, less than 1 centimeter. It's a low tumor grade, the clear margin, more than 2 millimeter. We talk with Dr. Mirkan about the margin. There's no lymphovascular infiltration. She has no chemotherapy, but she gets aromatase inhibitor for 5 years. And you can see that the IBTR will calculate a 10 years risk of local recurrence of 7.3% without any radiation and 2.2% with radiation. So that may pose us a number of questions about what should we treat and how aggressive should we be for the Western world. So clearly breast controlling therapy, and we have been through that through previous presentation. The whole purpose of breast treatment is first to remove the tumor, and that's what the surgeon do, and we heard that this morning. And then we know that a 1 centimeter tumor is 1 billion cells, if you make the math. So there could be some cell left behind. There could be some duct that contain some remaining disease. So the purpose of radiation is to treat those microscopic extension. And with a combination of systemic treatment to treat the distance micrometastasis, this is how we reach such good outcome of 99.1%. Basically, what we learned this morning, what we learned since now, is that by doing lumpectomy, breast controlling surgery, followed by radiation, the outcome are equivalent to mastectomy and allow for breast preservation. Now, like it was just said earlier on by Dr. Mirkan, 86% of the recurrence tend to occur around the surgical scar, very close to the index of the tumor. And high dose to small volume are well tolerated. So she mentioned that was a rationale for simultaneous integrated boost, but that's also a rationale for accelerated partial breast radiation, because we can give, if you have a small volume, bigger dose, faster, not having more cosmetic damage, but having the same equivalence of local control. So the first principle was suggested by a surgeon in the 1980s, but tested by the team of Frank Vicini in William Beaumont. And basically, they have treated about 190 patients, initially with LDR seeds, iodine, and later on with the breast HDR. And they pair match this patient 1-to-1 So it was a randomized pair match with the patient treated with whole breast radiotherapy. And in 2003, they published this article that really kicked up the theme. They got 1% local recurrence at 5 years with partial breast radiation compared to 1%. Those were early stage, node negative patients. So what are the techniques for partial breast radiation? Well, following the publication from William Beaumont, many teams engage in HDR brachytherapy. This is a patient that I treated when I was at Sunnybrook. Patients are receiving twice a day fraction, 10 fraction over 5 days after the placement of a catheter. So it's 34 gray in 8 fraction or I think we use 8 fractions, over 10 fraction, I think 34 gray in 10 fraction over 5 days. There's a typo here. And as you can see, it is an invasive procedure. So it's a little bit of a complex procedure because you need to get the patient the general anesthesia. You need after that to take the patient in the CT sim, do the dose optimization. You normally can give a first fraction on the first day, but then eventually you need to spread over the week and you tend to impinge on the other program like prostate brachy, gynae brachy, and sometimes it's difficult to squeeze a patient to a very busy program. To facilitate the technique, people invented, the same team in William Beaumont invented the idea of balloon HDR. It's simply a Foley catheter, a very expensive one, where you can put inside the HDR source. And if you place a balloon into the seroma, it can be done during the surgery, or often the US was done after the surgeon see the patient with the final result. Then the patient is sent to the radiotherapy center, and you can use a balloon to guide the source in the center of the seroma. Because the dose distribution is relatively even, but the source is far, so with the inverse square law, you still give a certain amount of dose to the surrounding tissues, the skin, the lung, and the heart. People develop also multi-channel balloon applicator, and you can see here the Contura various types of system. When we were in Canada, because the 8 fraction, the 10 fraction of the 5 day was a little bit of a challenge. And at the same time, we were also doing prostate brachytherapy, which is just one application in a single day. Patient go home and live a normal life. We developed a technique of permanent breast seeds implant, where patient get a CT sim, you contour your volume, and after that, exactly like for prostate brachy, you use a template to insert the needle, and you have stranded seed that you release around the surgical cavity, around the in the fibrotic area, so they tend to stay very, very stable. You see here a plan of a patient, and basically the dose is 90 gray that is delivered in a single fraction, but with palladium seeds with a half-life of 17 days, most of the radiation is delivered over 2 months. Brachytherapy is excellent technique, and we will see that the results are fabulous. It's the oldest technique evaluated for partial breast radiation. But not everybody has a brachy suite. Not everybody has access to the seeds. Not everybody has access to the balloons, the HDR, and it requires some skills. It's time consuming. So the same team that developed partial breast radiation with HDR, the team of Frank Vicini, proposed to use external beam, 3D CRT, SBRT, because you have several beam, and IMRT partial breast irradiation. And here's the dose is a little bit higher, 38 gray, delivered in 10 fraction over 5 days. And you can see here a patient where you would have a seroma that is contoured with various expansion margin, a little bit larger margin for the PTV because of possibility of setup error and motion error. And here's the volume that is treated. It's quite a larger volume. In the meantime, some surgeons were also interested by a technique of partial breast radiation. And you have Veronesi at the Istituto di Tumori di Milano, who developed intraoperative, meaning that the surgery, the lumpectomy will be performed inside a bunker of radiotherapy, and a beam of electron will deliver a single dose of 21 fraction. To protect the chest wall, often a piece of lead will be placed on the back of the seroma, which is concerning because this area will not obviously receive some radiation. And also, I mean, there's a challenge to to get access to a bunker and for several hours, the time that you deliver the radiation. So to avoid accessing a bunker, the team of IDEA in England developed the Target, which is a 50 kilovolt machine applicator. And you can see here that you insert a soft ball. The size is decided upon the patient. And at the end of the surgery, you put the applicator inside the tumor bed, you suture the tumor bed, and for 1 to 2 hours, because the 50 kilovolt has a very low dose rate, you will deliver a dose of 20 gray at the surface, which became a dose of 5 gray at 1 centimeter. So what are the results of all those techniques? I think the best study to report on the HDR technique is the Jackie Straw study. It's a large multi-center randomized trial testing non-inferiority of a dose of 30 gray in 8 fraction versus 50 gray in 25 fraction whole breast radiotherapy. And the study found that partial breast radiation using HDR is non-inferior. The local recurrence rate was 1.4 versus 0.9, and there was no difference in late grade 2-3 side effect. So this study was the first to publish some level 1 evidence that partial breast radiation was equivalence. Breast seeds implant, we don't have a phase 3 randomized trial, but we reported in 2015 the data out of 2 centers, our center and also British Columbia. And out of 134 patients with a 5-year median follow-up, we had a local recurrence of 1.2%. Among all the partial breast radiation, data is probably the lowest, but also for the seeds implant, we have ultra selection of patients because we really need to have small tumor and very clear margin and very small seroma. So it was a very favorable population, I would say. The 2 years long-term side effects are excellent, 3% telangiectasia, but grade 1, meaning just a dot on the skin, that compared to 30% with external beam radiation, 23% fibrosis, which is about, meaning an induration that you probably found also in external beam radiation. So it was very much equivalence to external beam radiation. 2019 was a big year for partial breast radiation because we have the report of 2 large multi-center randomized trials. First, the NSABP B39, led by Frank Vicini, which show a slightly increase of local recurrence at 4.6% with the partial breast radiation versus 3.9. Partial breast was delivered either by external beam, HDR brachytherapy, or myelocyte balloon. So everything was possible. When you look at the eligibility criteria of patient, they include patients with high risk of local recurrence, like lobular, like LVI positive, like extensive in situ carcinoma. And that may explain the 0.7% more excess of local recurrence. So it was not possible to conclude about the non-inferiority because the non-inferiority set was 0.5%, I think. But at least what we can say is that's probably, and I think it was reported later on, there's no impact on survival. And so, especially because they selected more risky patient, this proved that whatever technique, partial breast radiation is a concept that survived. The same year was reported the Canadian trial, the RAPID trial. So Tim Whelan copied the study from Frank Vicini, didn't accrue patient in the B39, but developed his own trial. And in this trial, he used a Canadian whole breast radiotherapy regimen, meaning 42.5 in 16 fraction, not 25 fraction like the B39, but 16 fraction. And same thing, you can see that at 8 years, the local recurrence for APBI 3% versus 2.8%. So this is really equivalent in terms of local recurrence. What the RAPID trial showed, though, was that there was less good cosmetic result with APBI. Like the number of fair and poor cosmetic result with APBIs was 31%, exactly the double as whole breast radiotherapy. And so there's been a lot of tentative to try to explain, was that because of the volume, was that because of maybe there's larger area in APBI receiving high dose. And the best explanation I got is from Ivo Livoto, who say, in fact, hypofractionation seems to lead to less long-term cosmetic damage. So in fact, the standard arm in the RAPID trial, 42.5 in 16, was better than the standard arm in the B39. It's unproven, but I think it's a very rational explanation. The Elliott trial, so the Elliott trial was the intraoperative electron trial done in Italy, showed that a negative trial, meaning that the local recurrence rate with intraoperative was 10 times higher, 4.4% versus 0.4%. And that has probably been because some selection in the IRT, because patients were larger, were node positive, but also the fact that you put a piece of lead in the bottom of the irradiation field that may protect the deepest part. When you look at the target trial, it was claimed that the trial was equivalent. In fact, this study is a bit complicated. A lot of patients, initially a first cohort of patients was treated with the delivery of IRT during the surgery. But they found that 30% of patients need a second operation because of positive margin. So the second part of the study, they did the intraoperative in two phases. First, an lumpectomy. Then when the patient was proven to be margin negative, they had a second irradiation. And if overall, you see the 5-year follow-up is 3.3% with the intraoperative versus 1.3% with external beam radiation, estimated non-inferior because less than 2.5%. In fact, when you look at the second series, you fail the non-inferiority. So the target has had a lot of appeal for surgeons who tend to use it a lot. On the other hand, the fact that it takes 1 to 2 hours is probably taking a toll, and you see that slowly the adoption of intraoperative is disappearing. If you compare the 5 years local recurrence for partial breast radiation, IBTR for those patients, if you use a nomogram, will predict about 1.5% local recurrence at 5 years with for those patients. The technique, there's some technique that yield 1 to 2% local recurrence at 5 years, and those are the HDR, the seeds, and the 3D CRT. Those are techniques that really yield some 5 years local recurrence, which are acceptable. And then you have the technique which lead 3 to 5% of local recurrence at 5 years, and are probably not acceptable. And I mean here the target, because the intraoperative kilovoltage applicator is 3.3%, definitively the electron intraoperative, and the balloon was associated with 3.8% local recurrence rate. 2 words about partial breast radiation and a little bit of a not frustration, but say a disappointment that really not really the type of patient that we see in Middle East, so we cannot develop such technique. Patient has to be older than 45 to 50 years old, has to be postmenopausal, and the majority of our patients tend to be 30 to 40 years old. It has to be a ductal histology excluding lobular feature, a unifocal tumor less than 3 centimeters in diameter, and the vast majority of our patients tend to be 5, 6 centimeters. The surgical margin has to be at least 2 millimeters, and so negative acting doesn't count here. You should not have lymphovascular infiltration, extensive in situ carcinoma, or nodal positivity, and that's typically not our kind of patient. Hormone receptors should be positive, and also the seroma should be easily identifiable and small, because if you have a very large seroma, there's no point of doing partial breast radiation. And all of that make that in the Western world, let's say 10 to 20% of the patient might be eligible for partial breast radiation, but so far, in my experience here, it's closer to 0%. What is the optimal accelerated partial breast radiation dose fractionation? The Florence team tested 30 gray in 5 fractions in 2 weeks, 3 fractions the first week, 2 fractions the second week. The fast forward that we talk about, that Dr. Alan Moran talked about, delivering the whole breast in 5 fractions, show that the optimal regimen is 26 gray in 5 fractions. So delivering 10 gray over 10 fractions over 5 days does not make a lot of sense. And there's no reason why today we could not deliver partial breast radiation faster. Probably in only 5 fractions, but maybe not over 2 weeks, but maybe over 1 week. And if we look at all the publication, I think that a 28 gray in 5 fractions over 1 week would be very reasonable, because you prescribe the dose in the center of a very small volume, and that means that the 90% isodose, which encompass your volume, will be closer to the 26 gray in 5 fraction. There's a lot of additional studies that are ongoing where people try to deliver the radiation in 3 fraction, 2 fraction, and even 1 fraction to mimic what is done with the target or the Elliott trial. But I think this is for the future. In terms of volume, I think we should stay safe and use the NSEBP 39 recommendation, meaning that you look at your seroma and you use the seroma plus a margin of 15 millimeter. We use 1 centimeter when we use the seeds because it was well-selected patient. And then you have a PTV, which is 10 millimeter in addition, and you evaluate all your treatment on PTV plus 7 millimeter. You can see that the 3 centimeter seroma, which is very small, ended up by being close to half a liter. So this was my last slide for the partial burst radiation, and also aiming to stay on time.